Hello, everyone. We'll be starting in just a minute. Good afternoon, everyone, and welcome on behalf of DataHaven. My name is Kara Strawn, and I'm a board member of DataHaven, as well as the Strategic Program Manager at the Community Foundation for Greater New Haven, and I will be facilitating today's session. Today's session is a special opportunity for Wellbeing Survey supporters to hear about early data and to offer real-time input into the survey. We hope you will offer your thoughts and questions in the chat bar. Throughout the sessions, guests will be muted and should use the chat function to provide comments and questions. Questions will be addressed toward the end of each session. This session is being recorded and will be made available after today. You are also encouraged to use the speaker view to be able to best view the sessions. Our time will be structured as outlined on the invitation. DataHaven Executive Director, Mark Abraham, will present early findings until about 1:30. From 1:30 to 2, COO for the state of Connecticut, Josh DeBall, will be interviewed by DataHaven board member and Director of Population Health at Yale Medicine, Rita Roy. We will then host 2 breakout sessions at 2 and 2:30 respectively. Facilitated by Fawati Mohammed Abo of Yale-New Haven Health. The second at 2:30 will focus on social and economic inclusion and will be facilitated by Kate Cervaki from the Hartford Foundation for Public Giving. You are welcome to stay for both breakout sessions or leave the meeting and return at a later time. You can use the same link to re-enter the meeting. And now it's my pleasure to introduce Mark Abraham, Executive Director of DataHaven, who is going to give us a first look at early data from the Wellbeing Survey. Mark?
Thank you, Kate. Thank you, Kara, for the introduction. And first, I'd just like to thank our sponsors for today's event. So the sponsors of the 2021 Community Wellbeing Survey are really important to the effort. They make the survey possible. And funding comes from throughout the state from public and private partners. This survey that is underway currently, it continues throughout the year and into next year with many community level reporting and assessment projects. So in addition to our core team and the survey team, we have partnerships with many of the sponsors listed here to produce town and neighborhood and regional reports about the data. And in many cases, we've been working together now for about 10 years or more in some cases to make this data available to communities in many different formats. So if you include the survey plus the community index, the new town equity reports, and additional surveying or other projects, we anticipate raising about $2 million this year for the project. We are, of course, like any project like this, we're still looking for funding to make the program as successful as possible. So I encourage you to contact us about that. And we're always looking for more sustainable partnerships to support this survey over time. It's been going on for 10 years, but we're really thinking about sort of what the next 10 years will look like as well. I just wanted to note this is not a complete list of the funders. Some of the funding sources are bundled and we're still receiving funding. So it's just a draft of the list of funders currently. I'm very grateful to our excellent speakers today. We'll be starting a little bit with some background about the project and then a brief overview of the results. But we really encourage you to stay for one or both of the in-depth sessions at 2 o'clock or 2:30 this afternoon, where our senior research associates, Kelly Davila and Camille Seaberry, will provide input on ongoing data collection. You'll have a chance to talk about your priorities for the survey, and they'll also be sharing some more interesting sort of trends from the results so far. So you might wonder how Connecticut is doing overall. And of course, this is the question we seek to answer through the Community Wellbeing Survey that asks questions about self-rated health and well-being in Connecticut, about economic life, community life, healthcare, and other assets. Connecticut, of course, is one of the healthiest states on average, and I think we all know that, but it's important to consider the distribution of well-being in the state. And many researchers now look at what's called the well-being inequality ratio. That's continued to rise over the past decade throughout pretty much all wealthy countries. That refers to the difference in well-being from sort of the top 10% to the bottom 10% of well-being. In the United States, we have a much larger difference in health and well-being than any of the other wealthy industrialized countries. And this difference helps account for the fact that while we spend twice as much on healthcare as other industrialized nations, we often rank near the bottom in terms of health outcomes among those wealthy countries on many measures. And Connecticut is no different. You can see here on the chart, there are large differences in well-being by income, for example. If you look at the percent of adults satisfied with life, it's about 50% for low-income adults, and it's about 90% for higher income adults. We also see differences by age, which seem to have been changing over time. In 2015, young adults and middle-aged and older adults had about the same level of life satisfaction. But since 2016, we've seen a divergence where young adults are less satisfied with life than their counterparts who are a bit older. That seems to have continued during the pandemic and is one of the more interesting things that we see in the current survey results. One of the ways to illustrate inequalities through maps of life expectancy. If you've seen our new town equity reports for all 169 towns in the state, you'll see maps like this throughout the reports. And if you've been involved in the survey, the DataHaven survey for a while, this is worth pointing out because those town reports contain more granular data from the survey than you may have seen in the past. We spent some time breaking it down for towns and also by race and ethnicity in new ways. These maps of redlining on the right, exclusionary zoning, incarceration, evictions, other things that we often overlay with higher rates of premature death or with life expectancy, they can help us understand the context behind these differences in well-being. And we think it's very important to do resident surveys about well-being because if you ask communities how well they're doing, something like health outcomes are not always the top issue that comes up. So in one community recently, for example, the conversation was all about raccoon infestations in attics that were not addressed in that community. For persons with mobility restrictions or disability, those restrictions and barriers that society prevents people from fully participating because of the way it's structured, those are often sort of top of mind for people who have those disabilities or other circumstances. And as Camille will talk about later in one of the breakout sessions, issues like trust in government, police-community relationships are also often surfacing as a concern in some communities. In many towns, we see that concerns about well-being relate to access to public services. So trust in government, trust with neighbors, and also just the responsiveness of government to their needs. These types of issues have been shown to influence how well we're doing as a state, possibly more than other measures like poverty rates or income. This chart on the screen is by Kelly Fong, now at Georgia Tech. It shows the association of DataHaven survey data about service availability in communities with the child report rate at the Department of Children and Families in Connecticut. And that measure of sort of whether services meet your needs, along with other measures in the survey, they're more predictive of the child report rate than other measures like poverty rates are. That kind of validates the concerns we hear expressed at community meetings, that exclusion from participation in government, feelings of power and belonging in communities, those can have an impact on people's lives more than sort of the numbers that come out from the census do. And of course, whether or not we're directly touched by these issues, those inequalities in well-being and quality of life, they really do impact the prosperity, the economic competitiveness of our state in the long term. Now I'll talk about survey methods from today's data release. Many of you should have the full file of data called the crosstabs for the survey, but if not, those will be posted on our site along with the press release from today. So I wanted to give you a little bit of background about the methods for the survey. The 2021 survey was designed with input from many of you. There were many other, not on this call, who are not funders, but who are advisory council members, which are organizations throughout the state that deal with various community issues, including public agencies. And that feedback was crucial for sort of ranking topics and then ranking specific items in the survey. People essentially submitted topics that they wanted to see in the survey or questions, and there was a voting process over two sessions to prioritize those items. One of the top issues that always comes up are questions about demographics. So if you compare the current survey that we do to the 2015 survey, there are many more questions in our survey now about demographics, including more detail, granular detail about race, ethnicity, and some others that we'll talk about in the presentation. Through August 30th this year, the live interviewers that we work with at Siena College have completed 5,145 interviews in English and Spanish. To do that, they had to spend 17,000 hours calling randomly selected landline and cell phone numbers. So a very labor-intensive process, but we are pleased with the cooperation rate as residents are reached. They're often about as willing to participate as in previous rounds of the survey. We are continuing to test new approaches to further oversample areas. There are alternatives to random digit dialing, but they're currently not as effective. They don't produce as representative of a sample of adults. And there's not a significant cost savings, especially if you're trying to target specific areas, but we are testing approaches like mailing postcards with incentives, and some of those may be incorporated going forward into this survey design in order to meet the goals of the survey. As the survey continues, another thing we're doing this year is more follow-up calls. So basically, if someone answers the survey in the first place, they are asked if they are willing to be recontacted for a further interview. And incentives are often offered in that case. So we may, if people agree to participate in another interview, we can call them back and provide a gift card for a longer sort of semi-structured interview. This is important because many of the things that we want to ask about in the survey, they don't lend themselves well to like a structured questionnaire or multiple choice. We want to explore some of these topics in more detail. So this is where your feedback today is very helpful for us in deciding what to include. We have some projects underway. We've interviewed parents about their experiences with remote learning technology in public schools. We have a project to interview older adults on specific issues, but there are many other topics that we would like to know more about. And again, your participation today will help enable that. So this slide will help you understand who's represented in the survey this year. We have a very good balance of men and women in our interviews, about the same level of participation, which is good. And then good participation across income groups, both low-income residents or residents with limited income, residents with higher incomes are represented well in the 5,145 interviews. And then, of course, we weight the main area where there's less representation is among the very young adults. People in their 20s basically are less likely to participate in surveys, but of course we weight their interviews more in our estimates. So there are 793 young adults who were interviewed. We weight those results to about 1,400 in the final estimate. So it does adjust based on the 2020 census data that was just released in August of this year. There's a good sample across different types of towns, rural areas, large cities, and by political party as well. And then some of the new demographics we added this year based on interest from you were questions about family member incarceration. We found about 30% of adults in the state have had family members incarcerated, which is very high, again, in the United States relative to other countries. So it is an important factor. You'll see some of the data later that shows it is an important factor in well-being. Many men included have been held in prison themselves. And then we also asked more detailed questions this year about disability. It turns out that the disability numbers were much higher in all of the city centers in Connecticut, which kind of makes me think about, transportation and housing access in cities in Connecticut, given that, some of these physical or mobility limitations could affect people's ability to get around in those large cities. And then there's, I'll just scratch the surface about kind of impacts of the pandemic as we go forward in a few additional slides. You'll be learning more about this in the press release. There's a lengthy document that discusses some of the pandemic impacts in that press release. And also during the sessions later today, you can learn more from Kelly and Camille about some of these more detailed issues that arose during the pandemic. But these are just a few points that I found interesting. One was 17% of adults in the state lost close friends or family due to COVID in the past year. 24% said that they had COVID themselves, including about 94,000 adults who had severe symptoms. So on like a scale, the most severe symptoms. So it's kind of, we did have questions in the survey for anyone who had symptoms of COVID, asking whether those symptoms affect their life, how long they've persisted, if they interfere with their daily activities, and those kind of questions. So those are things we can look at in more detail as the survey continues. About a quarter of adults lost their job during the pandemic, and 12% received meals from a food pantry. That's again, about 300,000 adults in the state. The numbers, of course, are much higher for families with children and for adults in city centers. There's some changing perceptions, as I alluded to earlier, with life satisfaction. We see in some cases, the perceptions are improving for older adults, like the perceptions that residents can find good jobs. That's actually risen during the pandemic, except for young adults. So the young adults still feel like their jobs are not available. And then the pandemic, of course, has affected people differently in the state. You can see that in this chart here. If you look at adults who are earning $15,000 a year or less, a small number are better off financially during the pandemic, but most are about the same or worse off. Whereas high-income adults in the state, most, about half are actually better off, saying they're better off financially during the pandemic than not, and only 7% report that they're worse off. So that can, the differences in kind of wealth accumulation during the pandemic and that kind of thing, and which jobs were retained, which jobs were lost, I think are very important to understand.
Mark, sorry to interrupt you. I'm getting a few messages that folks are having a hard time seeing the slides. So if you could maybe switch to full screen view.
Oh, is it not on full screen?
I think it's in presenter view, or it's not in presenter view. Sorry.
Oh, okay. Try. Sorry about that. Let's see if this works better. So this should be a little bit larger.
Yeah, I think that's better.
That's better. Sorry about that. So there's some good news in the survey that institutional trust, like trust in our government, is high in Connecticut. That is likely what led to the high rate of sort of compliance with executive orders and health promoting restrictions. During the pandemic, most adults place high levels of trust in state government, local health officials, especially at 90%. With the federal government, it's more mixed. It's about 50-50. And in rural areas, there's less trust in the federal government. In the city centers, there's a little bit more trust, but that gives you a sense of sort of the information people have access to. And these numbers have actually changed over the past year after the 2020 election to some degree. So there is sort of an aspect of that here. But overall, this is good that generally speaking, trust is high. We'll note that in the city centers, the urban core towns, so Bridgeport, Waterbury, New London, there is less reported trust in local institutions. Now I'll talk about some of the vaccine related data, because I think Josh and Brita will be discussing that as part of their conversation. So if you remember back in 2020, we conducted a smaller scale version of the DataHaven survey. This was before vaccines were available. And most adults were wearing masks often at that point in time, before the vaccines were available. Many more adults were working at home than currently. So if you look at that data, that's one thing that's changed quite a bit. And about 20% of adults at that point said they would not get vaccinated when the COVID vaccine became available. So if you fast forward now to this year, 1 year later, about 20% of adults are still not fully or partially vaccinated. So people were essentially, they had sort of made up their minds a year ago in some sense about whether they would be vaccinated or not, you could say, on the average. You'll notice that one thing that's interesting about this chart that shows the fully vaccinated rate, the partially vaccinated rate, is the partially vaccinated rate, so people who have received one dose of the vaccine but not both, is higher among Black and Latino adults in Connecticut. And this may be related to some of the reasons why people are getting vaccinated or not. One of the top reasons is worries about side effects and worrying about missing work due to side effects. So in some cases, people maybe have received the first dose of the vaccine, but maybe hesitant about the second dose due to that. Also, there could just be, and some of the other data will suggest this, just a need for more outreach to persons who have just had one dose or just haven't had the vaccine at all, in terms of getting them to prioritize that in their life. People are very busy, so they may just be putting it off, especially younger adults you can see who have lower rates of vaccination. So that sort of suggests continued need for outreach. And then this chart is a more complex one, but it shows that if you look at this total line in the middle of the chart, 83% are fully or partially vaccinated. And then you can see on the right side, 7% say they would definitely not get the vaccine, whereas about 10% say that they will, based on other things. So in other words, of the residents who are not vaccinated in Connecticut, more than half are willing to be vaccinated if the right conditions exist, is one way to interpret that. That does vary quite a bit. The responses about vaccine intention, though, they do vary by group. And one interesting difference is if you look at this light red bar, that's the percent who say they'll get the vaccine as soon as they can. It's quite a bit higher for low-income adults earning less than $30,000 a year, and also a bit higher for Black and Latino adults in Connecticut. And again, this is an indication that there could be barriers like not having time, not having a place to go that they trust, just access to healthcare. A lot of residents, when we ask the question about reasons, they mention the cost of getting a vaccine. Obviously, the vaccine is free, but maybe people think there's a cost associated with it. So you would be more sensitive to that as a person, struggling to pay bills, for example. And in our survey, we actually ask the specific reasons why people don't get vaccinated. So they're often related, again, like I said before, related to missing work due to side effects, the need to find trusted healthcare providers, misinformation about the vaccine in some cases, especially for residents who say they won't get it at all. Many of those residents believe that believe things about the vaccine that are not true. So there's a need for sort of combating misinformation and increasing access. This is the same chart I showed before, but it's now looking for other factors that predict vaccination rates even more than just demographics alone. So this shows that some of the community well-being factors I mentioned earlier, like trust, belonging in government, belonging in your town, social support, they're actually much more important in some ways in predicting access to or refusal to vaccines than just demographics. And you can see there's just a very large difference by political party between Democrat and Republican residents of the state. The largest differences here would be for folks who trust federal government. Most are vaccinated. Residents who don't trust federal government at all are much less likely to be vaccinated. Same with healthcare, especially among younger adults. And then some of these other factors are things we don't always think about, but may inform distribution of vaccines. So one is the social support question. It's a very commonly studied question. I know Brita, our next speaker, is familiar with this question more than I am, but social support is something that is just whether you have like friends or family who can help you out. So again, if you don't have friends who help you out, you're less likely to be vaccinated, and both for reasons about sort of waiting to see it, but also just not getting it. So there are issues there that potentially could be addressed through improved social support and counseling and access to support in that sense. Being financially comfortable, so residents who are under threat of eviction or do not have food, they may not prioritize vaccine. They may have other more pressing needs to address. So the vaccination rates, again, are very much lower for residents who are struggling financially. And like I mentioned earlier, we invite you to stay on for a more detailed discussion at 2. There's quite a bit more that Camille and Kelly will be presenting at that time. And look forward to your input and advice on how we can supplement this data as we do additional data collection, more focus groups, more targeted interviews. So thank you.
Great. Thank you, Mark. We have one question in the chat for you. Do you have any data on vaccination rates in Connecticut for pregnant people?
No, that could be a question. Maybe the next speaker might know more about that. We don't collect, in our survey, we don't ask about whether respondents are pregnant currently. We do look, however, at age, women of childbearing age, and often there's important differences to consider between women who have children recently or are of childbearing age and others. And generally speaking, the gender is not, unless it's interacting with something else, gender is not a big predictor of vaccination rates. Here, men and women both have fairly equal rates in most cases across those measures that I showed. But with pregnancy, there's obviously some specific concerns about the effect of the vaccine on pregnant women and on unborn children that are not covered in our survey, but are very important to think about too.
Great, thank you. That's very interesting. We have a few more minutes for questions. I'll encourage folks to just type in the chat if there's anything that's coming to mind. And if not, Mark, while folks are thinking, I would just ask you, what is most striking to you about this year's survey findings so far?
Yeah, so the slide that I started with showing sort of differences by age, I think are something we'd like to think about more, why we see like more anxiety among younger adults, more concerns about, quality of life and that type of thing. And it may be one thing that we've noticed, which Kelly, I think, or Camille will talk about a bit, is the issue of housing insecurity. And we do see, we did ask about evictions, like people who believe that they're going to be evicted from their home in the next 2 months. And that's an area where, like, for example, there's a vast difference. Most renters in the state are not worried about being evicted soon, but if you look at certain groups, like by age, there is kind of that concern that will happen. So that may be driving some of the differences we see by age, but there may be other factors that we're not considering when it comes to how healthy young people are in the state.
Great, thank you, Mark. Well, if there are no further questions, I would just want to say thank you again for all of the great work and data and findings that you're sharing, you and your team. And we will move on to the next set of presenters. So next up, we are pleased to have with us 2 leaders in Connecticut, Josh Jabal, Chief Operating Officer for the state, and Rita Roy, Director of Population Health at Yale Medicine. Welcome, and thank you both for being here today.
Thank you, Kara. It's really a pleasure to be here and to have the chance to talk with Josh about how the state of Connecticut really has been responding to the unique challenges created by the COVID-19 pandemic. And so with that, I guess my first comment and question is just that, we here in the state of Connecticut really have a fantastic opportunity to use data like the data that comes out of the Wellbeing Index to think about how we make trade-offs in the pandemic, right? The state had to make important decisions about stay-at-home orders or requiring masking, and any time we make those decisions to improve health outcomes and prevent the spread of illness, it also has trade-offs, for example, on the economy and on just people's overall sense of well-being. So I'm curious, how the state has been using these data to help inform some of those trade-offs as we moved through the course of the pandemic.
Yeah, well, thanks, Brita, for the question, and good afternoon, everybody. At first, I just want to start by thanking Mark and the DataHaven team for another really fascinating analysis of the state that really does help us understand what's going on and people's sentiments and the impacts that we're seeing of different factors on our state, particularly the pandemic over the last nearly 2 years now. So, big thanks to all of the sponsors who help make this work possible. Mark, thanks for showing that chart, a little trip down memory lane of that press conference over a year ago, where we did highlight some data from last year's survey, and it is fascinating to see how accurately people kind of predicted back then, whether they would be willing to be vaccinated or not. That was a pretty amazing reminder. But to your question, Britta, it throughout the pandemic, as you point out, every day the governor is presented with a set of trade-offs, usually choosing between the least bad option, because almost every decision he's had to make throughout the pandemic, has some sort of negative impacts associated with it, and really it's choosing the path that prevents the most harm or protects the most people. And when we have data and insights like this, it's helpful, right? It's helpful in informing those decisions and understanding the trade-offs, and then also seeing where the opportunities still lie in front of us. It probably won't surprise many to know that the part of the crosstabs I spent the most time rolling around in was the analysis around who's not yet vaccinated and why, right? And that's information and insight that is really helpful to our Department of Public Health, to policymakers, to the governor, as we think about the challenge in front of us of that remaining 20% who aren't yet fully vaccinated in Connecticut amongst the eligible population. That road gets harder and harder every day, right? And so, being able to do more and more micro-targeting, which has been a real strategy for us for months now, that type of analysis is really helpful.
Yeah, thanks for that. And to follow up a bit on the thoughts of how we get that final 20% vaccinated or most of them vaccinated. I'm curious about the idea of vaccine mandates. Of course, the president has already mandated that people that work in companies with more than 100 people will need to get vaccinated. But are there other mandates that the state might support, for example, in schools or other places to try to get more folks vaccinated? There was a significant contingent in the data that Mark just showed that people said they would get vaccinated if it was required. And maybe that would be just the amount of push to tip us over the edge.
Yeah, absolutely. And in each of the slices of the data of who's not yet vaccinated, I think has its own story associated with it. Certainly I think it was 17% of people who weren't yet vaccinated who said they would only if it was required for work, school, or other activities. So many people probably know back in August, the governor issued a series of executive orders that set in motion vaccine mandates for state employees, for long-term care facilities, in particular nursing homes and assisted living facilities, as well as for K through 12 educators and early childhood daycare providers. And so, we've kind of been in the throes of implementation over that, particularly over the last couple of weeks. And what we're seeing is similar to what I think has been seen in other organizations that have been a little ahead of us in this. In particular, our hospitals here in Connecticut, our acute care hospitals, voluntarily implemented vaccine mandates across the board, and have been implementing those. And similar to them, what we've seen is a non-trivial increase in vaccination rates as a result. It definitely comes with some challenges, but the people that probably self-identify in the survey is kind of waiting for their employer to give them that push, do in fact come forward and maybe use that mandate as the motivation to finally go out and get vaccinated. And so for state of Connecticut, what we've seen across roughly 31,000 employees is that since the state employee vaccine mandate was announced August 19th, I believe it was, Since then, we've seen over 1,700 state employees go ahead and get vaccinated, initiate their vaccination. So that's a meaningful bump. We're one of the largest employers in the state, and so when we can move the needle like that, it's helpful. And in fact, those mandates that the governor implemented through executive order back in August, when you include K through 12 educators, early childhood, long-term care, represented about 12% of the entire workforce in the state. So when you combine that with our hospitals, and then when you start to think about the other mandates that are coming through the president's orders, which are still, being worked out, we will have a very meaningful percentage of the overall workforce, and we'll probably be able to pick up the vast majority of the people, who identify in that category.
That's great. And we did see kind of similar trends as well at Yale, both at the university and in the health system, where also a vaccine mandate was implemented, and a significant proportion of people did go ahead and get vaccinated. While there were some ways for people to get exemptions, by and large, most people went ahead and got vaccinated, which is fantastic. So I'll also just say to everyone that is listening, if you have questions for Josh, please go ahead and put them in the chat. We will cover as many questions as we can in the time that we have allotted. But with the vaccines, and with what seems like a decrease in rates of the Delta variant, it seems like perhaps there's a light at the end of the tunnel here. Perhaps still a long tunnel, but I feel like we can see a glimpse. So how can data like this inform how we as a state can actually emerge better from the pandemic, in terms of both reducing the risks of transmission of COVID, flu, or other respiratory viruses, or also thinking kind of broader about health equity as a whole?
Yeah, no, absolutely. I mean, this is an area that we've been spending an awful lot of time on, particularly dating back to the budget cycle last spring, and all the work that we've put into the deployment of all of the federal resources that have come through between the CARES Act and the Recovery Plan Act. But the data show very clearly some things that really put a very kind of stark contrast on the challenges that a lot of people have endured through the pandemic. I mean, it does show. I mean, we should acknowledge as well that it shows the incredible recognition that the vast majority of people in the state have of what a great state this is, right? The rankings on quality of life and how great a place this is to raise children and find good jobs. But we do see also, the inequalities that do exist, particularly across income levels and in our cities. And then the impacts of the pandemic. Mark cited a couple of statistics, some others that caught my eye. I mean, a quarter of the state has lost a job during the pandemic, right? 12% of people in the state have gotten food from a food bank or a similar emergency food distribution site. Half of people in the state have a close friend or family member who's tested positive now. It's incredible. And 21% hospitalized, 17% have a close, 21% have a close friend or family member who's been hospitalized, and 17% have a close friend or family member who's died. Another amazing thing is half of people identified that they've put off healthcare due to the pandemic, even today, right? Or as of this summer when it was run, you would have thought maybe after that first wave or even the winter wave, people will be getting caught up. We still have half of people who put off healthcare, and that has follow-on implications that are very substantial, right? Where we still see hospitals being very busy, not so much with COVID these days, but with maybe a lot of that deferred care and complications resulting from that, which are a real priority focus area, and where we've put a lot of additional, the federal resources and our state resources to work. So, these are all areas that are front and center with the governor and his leadership team that we're, focused on, addressing going forward.
Thank you. And I'm starting to see a couple questions in the chat, so I'll turn to some of those. The first, I think, relates back to the conversation around vaccine mandates. And the question is whether individuals with exemptions be charged for weekly testing because they're not vaccinated.
So the way we're approaching this with our own employees, and each employer, obviously handles this to, as they see fit. But for our own employees at the state, what we've concluded is, first of all, I think many are aware that many of our state employees have an option to test out. They don't need to submit for a religious or medical exemption. We've given them that choice. The exception being employees who work in a hospital or long-term care type setting. They have the strict mandate. They do have the option for a religious or medical exemption, but then they have to test weekly. So for all employees who are testing, we are going to support the cost of that test. When we look at it and understand, the degree to which those costs could pile up, particularly relative to the levels of compensation a lot of the people are talking about, it's substantial. And we're trying to nudge and encourage people to get vaccinated, but we think that the way that will be more likely to take place is just based on the hassle and the inconvenience of getting tested, right? Having to take time out, and in this case, it will be your own time. It will not be state time to have to go to a testing site and get tested. If you're going to end up doing that weekly, that there's a non-trivial inconvenience associated with that. That even if you're not motivated by all of the other benefits of being vaccinated, hopefully that gets old and helps motivate people to go get vaccinated.
Another question from the chat is, how are we doing to anticipate added costs for the care of homeless in winter and respiratory virus season? For example, avoiding crowding, the flu and COVID vaccines, mental health and substance use services, and ultimately housing.
Yes, so this is an area of an enormous amount of work by a number of our commissioners. I think we've learned a lot through the pandemic too about strategies that can be very effective in terms of protecting many of our most vulnerable residents, in particular homeless. We've moved a lot of homeless into hotels and motels, particularly during some of the periods of highest infection. I mean, those tools are still available because we still have emergency declaration in place. The federal government is still paying for that, in fact. So that's resources that we're going to continue to take advantage of. But more broadly than that, in terms of other supports and services, whether it's, a lot of the work that's been done to expand healthcare access through the exchange and through a variety of, areas of Medicaid expansion, all the assistance that we're working to provide in terms of keeping people in their homes with the rental assistance programs, with mortgage assistance programs, and that's, just a few that off the top of my head. There's obviously many more, but I think your point about what's to come in the winter, when we typically experience seasonality on respiratory virus transmission, is really what we're worried about. And, we're often asked, why are you still following through on these mandates when the numbers are going down? And it seems like we've made it through Delta. And the answer, of course, is in your question, which is we need to be prepared for what may come this winter because, given the history of the seasonality in the Northeast here, I think it would be, probably irresponsible to not plan for, another uptick at some point here and be ready for that. Hopefully it doesn't come. Maybe I know there are some experts out there who think maybe that was our Delta wave and maybe we're now through the worst of it. We can all hope that, right? But our job is to plan for the worst and be ready to try to mitigate any future impacts.
Yeah, I think that's great to think about. I mean, we are already seeing increases in just common colds, other respiratory viruses emerge, especially among children, and so it's good to be prepared, as you said. Finally, you mentioned some things that you noted in the survey results. Was there anything else from the survey results that really surprised you that you maybe did not expect to see?
There again, back on the, kind of the focus on the profile of people who are still not vaccinated. That it was interesting to see how that breaks down. Particularly I think it was about 44% of those people were in the definitely no vaccination category, which I guess is probably what we would more or less expect. But, it was interesting to look at how those folks break down too. There was very little differentiation by educational level. I thought was interesting. It was pretty consistent across levels of education. And in some areas, it almost looked like the percentages were higher among high income levels. Maybe there's a smaller, N there of people who have not yet gotten vaccinated. So you've kind of honed in more directly on the real hardcore anti-vaxxers there, perhaps. Maybe that's why the percentage is a little lower, because there's no one really left in the as soon as I can category there in those higher income levels. So that might be the explanation, but that was definitely interesting. It was good to see that, there weren't a lot of concerns in that group of the not yet vaccinated around lack of access. The numbers were low in terms of concerns about being able to get time off or transportation or cost. I mean, there were a few, so there's still some people to get through, but those numbers were very low. Really what the greatest opportunity clearly is, those who say, I'll eventually get it, which is, our continuing kind of motivation every day, where we're out there with, 30 mobile vans and, 800 sites around the state, and a never ending effort to do communications and outreach and trusted messenger campaigns and door-to-door knocking. But it's, it's one arm at a time at this point. And so, seeing that there are still, when the survey closed, I guess in August, we probably vaccinated another 150,000 people since then. So those numbers are probably even lower today than they were back then. But, that is the challenge in front of us, to continue to reach out and to connect with those folks in whatever way we can. Even in the strong, definitely no category, people change their minds there. There's a website a friend pointed me to recently called Sorry Anti-Vaxxer. I don't know if people have seen this, but it's kind of stories of people, often prominent anti-vaxxers, who got COVID and often died or had a loved one die. And you read these stories and they're incredibly sad. And some people come through them, they lose a spouse and their mind's unchanged. But what you do see there is that, some people figure it out, unfortunately, the hard way. And so our hope is that, through some of the work that we do, we can get through to those people before it's too late, and before it hits too close to home. So that's the challenge in front of us.
Mm-hmm. I haven't seen that site, but I will definitely look that up. Another question from the chat is that, each town is handling mask mandates differently in Connecticut. And so the question is why the governor is not imposing a statewide mask mandate to protect public health.
Yes. So, we have, kept in place an executive order in the highest risk environments, particularly hospitals, long-term care facilities, public transportation, and most famously schools, where we have significant numbers of people in close quarters, many of whom are not yet eligible for vaccination, where the governor's view has been that we do need a uniform approach there. Now, for more broadly, the governor's judgment was that we can leave that up to towns. They have widely different vaccination rates, widely different risk profiles in terms of the density and the activities in those towns. Look, we're also in a position now today where, clearly the metrics are trending downward. As mentioned previously, we don't know what the future holds, but I don't think it's a time where we're looking to, further tighten up restrictions at this point.
If you had the opportunity, what other questions would you add to the DataHaven survey potentially this fall? Well,
I'm very grateful for Mark, because he'll occasionally reach out and say, hey, he'll ask me that exact same question. And so, I was really grateful that some of the questions in here help address questions that we have. So this is again, back to Mark and the team and the people who sponsor this work and make it possible. There is a direct connection here between the work that you do and the information that ends up, going to the governor and to the people, making policy around how we respond during the pandemic here. So we're very grateful for that. But we'll keep those lines of communication wide open, I'm sure. And I really appreciate the enthusiasm with which this group is eager to partner with us to try to make the most informed, data-driven decisions that we can.
That's great. And I'm not seeing another question in the chat at the moment. So why don't we turn the tables around for a second and see if Mark or Kara have any questions for you.
Just the one question I have is more so speculation. I'm recently reading that more families are expressing interest and willingness to get their children ages 5 to 11 vaccinated once the FDA approves that. And I'm just wondering what your predictions or thoughts or plans in terms of the vaccination rollout for that particular age group.
Yeah, no, we're really excited about that. I mean, all indications are that that could happen, in a month or so. We've been working hard through the summer to outreach to pediatricians and pediatric practices to enroll them in the state's vaccination program. I think all of us who are parents who've had children of that age recognize that marching them into a mass vaccination site may not be the ideal approach. And so, we're excited that by the time, the emergency use authorization is extended to younger children, that the vast majority of them will be able to get vaccinated at their pediatrician's office, where they get the rest of their childhood immunizations, as well as, possibly, likely going to some of the other more traditional channels, whether it's pharmacies or our hospital vaccination sites. So we'll be ready for that. We are encouraged that we think a lot of parents are really eager for that moment, and that we'll see similarly high vaccination rates among the younger kids that we've seen amongst the teenagers. One other thing, Britta, back on your earlier question about other kind of surprising insights from the survey, and Mark put up the chart too, but the trust levels in different governmental institutions, and in particular, this kind of general theme that the closer you get to where someone lives, right, the more trust they have in that organization. And in particular, the organizations that ranked highest were local health officials, which is an interesting insight for the state of Connecticut in particular, where we have this kind of very fragmented map of 64 local health departments with very, a wide distribution of capabilities across those 64 organizations. And we've seen that throughout the pandemic of some who took incredibly active roles from the very early days straight through the vaccination campaigns, and others, less so, for a variety of reasons, often, just coming back to staffing or leadership. But if that is really the greatest source of trust, obviously we will always endeavor to build as much trust as we can at the state level, and I'm sure that our federal partners feel the same way. But if that's where the trust is highest today, what more we can or need to do to ensure that those organizations are appropriately enabled to do the work on the ground, recognizing the trust that they do have. So we've pumped tens of millions of dollars into local health through the pandemic, and we've partnered very closely with them, with our state Department of Public Health, with a lot of really, really great partnerships there. But it's a good insight that suggests that needs to be a very strong area of continued focus going forward.
Yeah, absolutely. And I think the administration should be applauded, for the way that you've really reached out to the various health departments across the state and tried to coordinate among them. It's always a challenge to do. But I think that partnership has been noted and noticed in a positive way in the various towns across Connecticut. And a related question that we now have in the chat is whether you see a plan for building an equitable public health infrastructure as a result of the experiences in this pandemic, and looking across the early results of the Wellbeing Survey. The author of the question is thinking here more of like a health in all policies type of idea, again, sort of in partnership with the public health infrastructure across the state.
Yeah, and the short answer is yes, absolutely. And, throughout the pandemic at each phase, we've seen the disparities in outcomes related to who's testing positive, who's suffering severe outcomes, the rate at which people were receiving vaccination, some of the challenges associated with access in the early days, and other factors that have resulted even today, in some, non-trivial disparities in terms of the vaccination rates. And I know that this has been something we've spent an enormous amount of time on throughout this, focusing on strategies to close those gaps, to provide resources to people who have been on the, in the populations that have been most adversely impacted. This is an area of tremendous passion for our new public health commissioner, Dr. Manisha Justani. She's incredibly focused on this. I think spending a lot of time already in outreach to stakeholders to talk about strategies here. So, absolutely, this is an area the governor's passionate about, that, our whole administration is very focused on, and where we obviously have, like every state, candidly, right, an enormous amount of opportunity for improvement.
Absolutely. All right, well, I think we're almost nearing the end of time for this segment. So let me take a moment here to thank you again for taking this time to be here with us today. And also to thank you and the governor and the administration for overall really a fantastic response to the pandemic, and a lot of really kind of innovative and locally partnered ways to get more people vaccinated and vaccinated quickly. Connecticut has really led the country for really the entire pandemic in our rates of vaccinations, how quickly we've got people vaccinated. And so, that certainly requires a strong leadership from the state and from local partners, as far as health departments and health systems across the state as well. So let me turn it now back to Cara to move us forward to the next segment.
Thank you, Brita, and thank you, Josh. We will now be moving into our breakout sessions, where Wellbeing Survey supporters will have the opportunity to provide input and feedback into this year's data collection. And in leading this session will be Fawati Mohammed Abo, who is community health epidemiologist at Yale-New Haven Health, who will be leading the conversation about healthcare and COVID. So Fawati.
Thank you, Cara. Good afternoon, everybody. I'm so pleased and honored to be facilitating this session about healthcare and COVID-19. My name is Fawati Mohammed Abo. I'm the community health epidemiologist at L&M Hospital of Yale-New Haven Health System. I'm also a teaching faculty at the UConn program in Applied Public Health Sciences. It's my pleasure to go over a few steps before we start this breakout session. We are going to have a brief presentation on some additional materials that pertain to healthcare and healthcare access in particular. And then during the presentation, please feel free to pose your questions in the chat. If you have any comments or recommending any questions to be added to the DataHaven Wellbeing Survey in this particular aspect. We will try, if we have time at the end of the 30-minute allotted for this session, to give the opportunity to some of you to speak up and share your opinions verbally, and if you have any questions that you would like to talk about them. So it's my pleasure to introduce Kelly Davila, Senior Research Associate from DataHaven, who will be sharing a few slides on healthcare and COVID-19. Kelly?
Thank you. Let me share my screen. Can everybody see this? Okay. Hi, my name is Kelly Davila. I'm a Senior Research Associate at DataHaven. I'm going to cover briefly a few different topics that we have added to the survey this year, and then also kind of contextualizing how the pandemic has affected different aspects of well-being over time. This is the fourth iteration of the survey, as Mark mentioned, so we're able to illuminate some trends, but I'll focus primarily on some 2021 data. And again, just a reminder to please let us know if there's anything that you would like to see us add to different focus groups and interviews as we proceed throughout the year with following up on some of the respondents. So as was mentioned previously, we're noticing that a lot of people who went without healthcare or postponed healthcare during the course of the pandemic in 2020, we're seeing a little bit of a trend now that some people are just forgoing healthcare overall. As was mentioned before, this is going to have different effects on not only the healthcare system, but on individuals' healthcare behaviors. So one of the trends that we're seeing is that a lot of both Latino and low-income adults are increasingly less likely to seek healthcare compared to other groups. Health insurance overall has improved across the state, but still remains high among some groups, notably again, Latino adults and low-income adults. We're seeing increasingly that young people are, not likely to have a medical home or a doctor someplace that they consider the place where they routinely get healthcare. And as we have seen previously too, those are two groups that are, a little less likely to have gotten vaccinated, perhaps because they don't have that healthcare relationship that other groups do. We're also seeing a decline in dental visits over the course of the pandemic and continuing into 2021. The survey does look at some of the reasons why different healthcare is being skipped or postponed. That's not being shown here, but if there are questions about that, we can certainly talk about those. So one of the trends that we did notice this year is that the cost, or rather I should say, people who are unable to afford prescriptions, that has improved considerably. And we're thinking that might be due to the effect of stimulus payments and expanded unemployment benefits that have led some people to have a little bit more expendable income to spend on things like prescriptions, where they may not have had that small bit of financial security previously. But despite improvements and despite the largest improvements, again, Latino and low-income adults are the least likely, or I should say, have a higher rate of being unable to afford prescriptions. But across the board, prescription affordability has improved quite a bit from 2018 to August 2021. Looking at a couple of healthcare outcomes or health outcomes, asthma is a new metric that we're starting to look at. So we don't have much trend information here quite yet, but we do see that a quarter of Latinos, of all ages, adults of all ages have asthma or report that they have asthma. Diabetes is something that's more common among especially Black adults, but older adults in general. And smoking rates, while they have improved over the past 6 years, continue to be elevated among Black and Latino adults. And finally, this is a chart that, for those of you who read our health equity report released last year, this is kind of an updated version of that, but looking at the share of people who report levels of anxiety versus their levels of self-reported health. We do see that people who report more anxiety report lower self-reported health, with some outliers, notably young adults report being a little bit more, much more anxious, but in better health, presumably because they're younger, while low-income adults are much more anxious and lower health. So this is just a short relationship of how different healthcare behaviors or healthcare outcomes might vary by group. And that is all I've got for presentation. If there are any questions in the chat, we are happy to answer.
Thank you, Kelly, for this summary about healthcare access during this time. And I would like to read one question from the chat. with more individuals on Medicaid during the pandemic, which has no cost sharing for the majority of members, would be interested to see individuals who are not on Medicaid thoughts on prescription drug affordability. So this is a question came to me directly through a direct message regarding specifically regarding prescription affordability, which is so interesting that you shared. We see more affordability for prescriptions despite these higher rates of unemployment.
Yeah, it's kind of a complex relationship. Also, in the past 3 years, there have been a couple of bills, I want to say at the federal level, aimed at more transparency in terms of prescription pricing. So whether or not that has had an effect on affordability overall, I mean, we're not really, in our survey, able to tease that apart. But also, yes, I mean, Medicare is going to have a different prescription affordability than, or public insurance in general will have different prescription affordabilities than people on private insurance or who are insured through their employer. So that's certainly something that we can unpack a little bit in follow-up interviews.
Yes, and I think maybe a follow-up question will be, do we have a question about, do we have data on the interaction or the correlation between the type of insurance and those who have the prescription affordability, if I get exactly what the author of the question was pointing to. So do we have data that have this cross-tabulation between the type of insurance and prescription affordability?
No, we don't. Our survey doesn't ask what kind of insurance somebody has, although, you know, with those over 65, I think we can assume that there's probably a significant number of those individuals who have Medicare. But the survey doesn't ask that necessarily. We are able to look at, independent of the survey data, correlations between people by age and their the share of those groups who might be enrolled in different public insurances. Because so many of those are income-based, so that's going to vary by age, with more children and more seniors being on public insurance. So, but our survey is not able to tease that apart.
Okay, thank you so much. I would just like to note that please go ahead and post your questions in the chat. And if we have time at the end of this session, we will open it up for those who would like to speak up and share their thoughts or questions. There is another question regarding a question in the chat regarding, yes, there is any data from the survey that shows whether people are were frightened to go to healthcare, despite the fact that vaccinations rates are higher now, that there were some hesitancy to go or fear from going to healthcare, for instance, to catch COVID?
No, I don't think that's included in our questions about why healthcare might have been postponed, although what we might be able to do is run a cross tabulation between those who are vaccinated and those who went without healthcare, to see if there's a relationship between the two of those. It's because it's looking at the past year, the question is like, in the past year, did you postpone or skip healthcare? In many cases, many of us have not been vaccinated for a full year. So like, for example, I would answer yes to that, even though I'm vaccinated now and have tried to get back on routine healthcare. But that might be complicating that answer a little bit.
Thank you so much. And there is another question that we had seen during the pandemic, the role of community health workers rise up, and they have been engaged with community members and do health education and so on. So these positions for community health workers were funded mostly by grant money, by grant funding. I think this is a question maybe to Josh to jump in if he would like to answer, that if there is at the state level, if there is an effort to make these positions permanently or to provide support or to use this model of depending on utilizing community health workers, is this approach, is there direction to integrate this approach into the healthcare system? I think this is a very interesting question. Do you want to comment, Kelly?
I cannot say that. Is there any plans to do that? But yeah, it would be great if that were something that would continue, because I think a lot of people who, again, talking about people who don't have a medical home necessarily, but may have a trusted community organization, that's just, one more mechanism that can promote healthcare in the community.
Yes, absolutely. And we had seen in the data that there are trust issues. Some subgroups in particular have less trust or lack of trust in healthcare systems or in providers or in the government. So I think utilizing this approach of hiring community or integrating community health workers in the system will be helpful and beneficial. I would like to pass this question to Josh, if you are still here with us, if you would like to comment on that. Is the state considering funding or establishing this model, providing support to community health workers? If there is any directions towards that, if Josh is available. Okay, so we will reach out with this question and try to have an answer later on. We have other questions in the chat. One question is, do we have anything about access to healthcare in relation to sanctuary cities or towns that are more vocally open and accepting to undocumented individuals?
The survey doesn't necessarily ask that, although because we run interviews with adults in each Connecticut town. So in many cases, we're able to talk about things at the town level. It might be slicing it a little bit too thin to look at just those cities that are considered sanctuary cities by whichever metrics you would like to use for that, and then looking at different trust in healthcare. So I want to say that's maybe a better kind of national question than Connecticut-based question. Our survey doesn't necessarily get at that.
Okay, thank you so much. So all of these questions will also raise the potentials of more questions to be added to the survey in the second round. Mm-hmm. So thank you to all of you who raised these issues. There is also another question sent directly to me that somebody mentioned. I don't know, it's a question or a comment. Somebody mentioned it that the State Office of Health Strategy is in the process of standardizing certification for community health workers. Thank you, Lori, for sharing that. And that this training and their affiliation with healthcare systems could be formally integrated and reimbursed. Their services could be reimbursed by Medicaid. That's very good news. And I'm personally advocating for that model because I know the role of community health workers as liaisons between the healthcare system in general and the population in need or the communities receiving the services. They do a good job explaining the culture and the needs of each individual as well as certain subpopulations. So we hope that the Office of Health Strategy gains success in establishing this system. There is a question, is there information on language and healthcare access and or ability to access translation services and the ability to navigate the healthcare system and or health literacy, which is again taking us to that area of interest that on people who are certain subpopulations, those who have language barriers or specific cultures that has difficulties in accessing healthcare, not necessarily due to lack of health insurance, but it could be due to these other social barriers to health. What do you think? Is the survey has any information about that?
The survey does not, but I think that would be a good question to add. In the health equity report that we put out last year, we did look at linguistic isolation. So that's the share of people who speak English less than very well, which is the census's term. And whether or not those individuals are concentrated in certain areas. And one of the findings that we saw there was that in rural areas, especially Asian populations, have higher levels of linguistic isolation, which could be problematic because presumably in rural areas, you might not have the number of resources available as urban areas where translators might be available at a hospital. There might be a reliance on children or family members needing to come along and translate in some healthcare aspects. So that would be an interesting question to add to the survey, if not a follow-up interview, to do with some people who postponed or put off healthcare in general.
Excellent. I think that would be a great addition to the survey, especially to address inequities for certain groups that had them for a longer time, and these inequities are exposed now due to COVID-19 and to by the circumstances surrounding COVID-19. So I have a question. Do you want to comment on that?
I just want to tack on one more thing. What the survey does ask is whether individuals have felt discriminated against in a healthcare context, and one of the responses to that is feeling discriminated against based on their race, ethnicity, or origin. So that's one additional element that we do have survey data for. Sorry, go ahead.
Thank you for sharing that. So I have one question for you, Kelly. It's regarding status of health insurance rate. We know that from previous survey data that those who are uninsured tend to be mostly those of certain subpopulations, like those who are Black or African Americans, those who are low-income communities, some Hispanic or Latinx communities. So currently, with this round of data, do you see changes in the health insurance rate, especially that there are higher rate of unemployment due to COVID?
Mm-hmm.
Do you think that affected the uninsurance rate in general and for these subpopulations?
Yeah, so the survey surprisingly did not reflect a drop in health insurance status given the rise in unemployment. So whether or not that's related to COBRA or an open enrollment period for different marketplace insurances that I want to say opened last November or so for the newly unemployed, we didn't see a drop in that, which is great. But that being said, uninsurance rates still remain high among the groups that you mentioned.
So we see some inequities here in the data, right? That it's overall, we do not see drop in an insurance rate, but when we break it down by race, ethnicity, we might see populations who suffer more from this. I think it would be so interesting to look at this in more details and to study this more in depth, because I think one of the factors that we all experience every day, that we see the inequities that's been very exposed by COVID-19 pandemic. That doesn't mean those inequities were not there before. They have been here since long time, but now during the pandemic, they were very seen and they are still seen by everybody. And I think we shouldn't let this time go away or this chance, and we should try to focus on providing more support to subpopulations that have higher needs than others. So there is a question in the chat. The author said, "Can you speak more about the organization of the survey? Why we have 2 rounds? Is this preliminary data subject to change?" So it's a question about the survey organization itself.
Yeah, I think Mark answered that in the chat. It's not necessarily 2 rounds. The survey is ongoing. So the data that we're presenting is through August 31st. We just had to have a cutoff point so we could analyze it and get this presentation together for you all. So we'll continue to run the survey as normal, but the survey itself is pretty vast. The questionnaire can last about 20 minutes, and there are different kind of panels of questions. So not everybody is asked every single question, but certain people are selected to answer more questions than others. So yeah, it's not that we're changing the questions necessarily, but we would like to, as Mark mentioned, do some follow-up interviews or focus groups that can get more, can illuminate some more detail in terms of, the why behind some of these answers that the survey is not necessarily able to get to.
Thank you, Kelly, for clarifying that, and thank you, Mark, for answering this question in the chat. I have a follow-up question to that based on this answer. So previous years or previous rounds of survey, like the 2018 or the 2015 DataHaven Community Wellbeing Survey, was there a specific time period during the year where the survey was implemented, or it was still on an ongoing process the way it is right now? Mark,
yeah,
Want me to take that question?
Yeah, Mark, could answer
yeah,
that.
so the surveys generally start in the spring and go through the end of the year. So in this case, we started like technically in May and we go through the end of the year. So it's similar for the full year surveys. The August 2020 survey was a much smaller version we just did in like a couple of weeks. So that one was just done pretty much in August of last year. So that, hopefully that helps, but.
Thank you. Thank you, Mark. And I think these are all great thoughts and great questions from the participants. Please keep on adding your questions to the chat. I do have one more question to Kelly. We saw earlier when Mark presented at the beginning the slides of this round of data that 17% of Connecticut residents had COVID-19 or tested positive for COVID-19. Do we have that indicator broken down by race, ethnicity, or by any other subcategories?
We do. I did not show that in this slide. I feel like in our press release for the COVID data, we released that information. We can certainly put out an updated chart. The state also has that data available by race, ethnicity. So we also have it by race, ethnicity, income, presence of children at home, income level, I said that, and age group.
Excellent, yes, because I think many of us will be eager to see how certain populations or certain groups or certain age categories were more affected or less affected by COVID than others. Mm-hmm. And I would just like to note that please, if you would like to speak up or if you want to talk about your comments here, providing feedback or asking questions, please use the reactions tab at the bottom to raise your hand, and you will be unmuted to speak. There is another question also came before that we had seen rates of asthma, diabetes, and also smoking rates are affecting specifically older Black populations. Do you had seen in the data any relationship between these chronic diseases and risk factors and the coronavirus infection? Was there any correlation between the two?
Yeah, I guess we would anticipate that we'd see a relationship between the two. We can run crosstabs on the presence of things like diabetes and whether or not somebody got coronavirus, but those for the survey data, that number would be pretty small, so we wouldn't necessarily be able to say trends about that at anything maybe less than the state level. But nationally, we did see a lot of correlation between those kinds of like vascular illnesses and things like smoking rates, and then more severe COVID-19 symptoms, or a higher likelihood of having gotten it, especially early in the pandemic before vaccines.
Thank you very much. Please use the reactions tab if you would like to raise your hand and share your thoughts or your questions. There is a question in the chat. Can you speak to the granularity of race ethnicity data being collected in the survey? And are there certain data points with sufficient data to disaggregate and report beyond OMB?
Yeah, so the race ethnicity categories that we have are listed as white/Caucasian, Black/African American, Hispanic or Latino, Asian, Native American, and other race. Those are not necessarily the OMB or census terminology, but that's what we have. So in that case, I guess we're not really able to disaggregate any further. For example, we
have more follow-up questions in the crosstabs that you have. They're not detailed, but if someone says they're Latino, for example, we have like some more detailed questions about Puerto Rican versus Mexican and for Asian and stuff. So we have broken those out, like for the health equity report that Kelly authored last year. Sometimes we broke out like Puerto Ricans versus other Latina, and then same for Asian American groups. So it's just not not something we do in the crosstab because the groups are smaller. I think they require a little bit more statistical care to report.
Yes, thank you so much, Mark, for sharing that. We have a question in the chat. It's an interesting one. So how are people reacting to being called for the survey? Are they getting, are you getting a lot of hang-ups or refusers, or how does it feel, the experience of interviewing residents randomly?
Mark, do you want to?
Yeah, I can talk about that. So when people are reached in the survey, there's something called the cooperation rate, which is like, do they want to speak to the interviewer? And that's been pretty stable over the past few decades. So usually like 1 in 5 people are like, yeah, I have time to participate. Sometimes they say they're too busy, so we schedule appointments and call them back, several times or a few days later. So that's helpful to get participation. For the people who cooperate and want to take the survey, like they're very positive. All the questions that we use in the survey, they've been like tested. So there are not a lot of questions that like sort of would cause people to refuse to answer or to hang up, with the exception, there isn't a question about your income level. And that's always the question we put at the very end, because you get, 10 or 15% of people who don't want to answer that question. But that's sort of true across all surveys.
Was this, okay, go ahead. Was this experience different this time during the pandemic when you have done this interviewing in the middle of a pandemic? Was the responses are the same or a little bit different?
Yeah, they're pretty much the same. Like people enjoy talking about their neighborhoods. We start with a question about like, do you think your neighborhood's improving or not, sort of. So people like to answer about, there's like questions about where you buy food and stores, and it goes through sort of a wide range of topics. So generally speaking, people like to complete the whole survey. So that's good. If they start the survey, they're very likely to go through all the way to the end. So, obviously we only count them in the sample if they finish the whole survey. So that's good.
Thank you so much, Mark. And thank you, Kelly. I see that we are at 2:29. We are almost done with this session. Thank you to all the participants who shared their questions and thoughts in the chat. We hope to continue these conversations in other DataHaven events. And thank you, Mark and all the team for putting this together. I will give it now to Kara.
Thank you. And I'm just going to continue adding on the thank yous to you, Fawati, for leading a great discussion. So we're going to move on into the second breakout session now, which is going to be led by Kate Cervaki, who's Director of Strategic Learning and Evaluation at the Hartford Foundation for Public Giving. And she is going to be leading the conversation on social and economic inclusion. Kate?
Thank you so much. My name is Kate Sobaki. I am the Director of Strategic Learning and Evaluation at the Hartford Foundation for Public Giving. In that role, part of my job is to support and contribute to the strength of the data ecosystem. And I think it goes without saying that the DataHaven Wellbeing Survey and the index is a critical part of that strength in the data ecosystem in the state. And we are so thankful to be a contributor to it. I'm excited and pleased to be facilitating this breakout session on economic and social inclusion, and to give us a little roadmap Fouadi already kind of outlined it, and this session will be similar. Camille Seabury will be presenting some additional material. Camille is a senior research associate at DataHaven. And during that time, you are encouraged and welcome to enter questions in the chat or to make suggestions, comments, recommendations, and we will attend to those. If we do have time, we will be able to let people speak up and voice their questions or comments at the very end. But until then, I'll turn it over to you, Camille, for the presentation of additional material. Thank you.
All right. Hi, everybody. Thanks. I will be pretty brief, partly because I have a cold and I'm going to try and not be sneezing in people's headphones. But I will just be going over some of the additional things that we study at DataHaven that come from the survey, get into kind of the less the direct health and healthcare access sorts of questions, but also the other factors that go into people's health and people's just kind of more holistic well-being, access to care. So we do look a lot at socioeconomic factors, sort of the social determinants of health. And that, as people have mentioned already, those are some of the things that have really been at the forefront of really all facets of being in a pandemic. So not just who is getting sick, but who's most kind of protected from if they do get sick, things like, are you at risk of losing your job? Are you at risk of losing your home? Do your kids have the resources that they need to be in school when school suddenly is at home and on the internet? So this is just a little bit of the data that we have collected that kind of relates to that. And some of these are questions that we look at every round of the survey, every iteration, that are kind of, you know, again, like people have mentioned, factors that were already there before COVID, factors that unfortunately will probably be still issues after COVID, but some of the kind of groundwork almost for the pandemic. So one of the things that we see just kind of across the board on these different measures of financial security, basic needs being met, are patterns where we see greater difficulty with meeting just basic needs among Black and Latino adults, among lower income adults, specifically populations within the urban core towns, so kind of just the major cities in the state. So we see that across kind of, I can give definitions of these, but so housing insecurity is asked as if you, at any point in the past 12 months, did you have difficulty paying for adequate housing for yourself or your family? And so we see overall 8% for that, but then higher for lower income adults, higher in the cities, higher for Black and Latino adults. Food insecurity similarly is at any point in the past 12 months, were you unable to provide food for yourself or your family? And then financial insecurity is, we ask it as kind of on a scale of how well you're managing financially. And so financial insecurity is that you say that you're just getting by. So yeah, so again, these are kind of the patterns that we saw pre-pandemic. We're seeing them again during pandemic. And that then is going to affect, you know, all sorts of outcomes of both health outcomes, should you get sick, your ability to kind of weather the situations that are changing. we looked some at trends. So again, we have questions that we ask every time that have been, especially interesting because especially interesting for studying COVID because we have these baselines going back to 2015 of the same questions being asked. So one of those is underemployment, which we define as either not working, but wanting to work, or you are working, you're working part-time, you would prefer to be working full-time. So that gets at more, kind of encompasses more than the official unemployment definitions, which are just like you're out of work and you're actively looking for work. This gets to more, you are out of work, you may or may not be actively looking based on, Department of Labor definition, but also just you're not working as much as you need to be able to work. And so this, we kind of always see these divides by race, by income, by education. Traditionally, we've seen those, but then we've seen some of these divides really open up, especially last year. And then something that's interesting with a few of the trends, this one in particular, but also food insecurity and financial insecurity. Some of these measures, things have already gotten a lot better in just over the course of the past year. And that's one of those sorts of things where we have the data on it. We can look at the numbers about it, but not necessarily be able to say why this happened. So some of the things that Kelly was mentioning, where there might be policy changes affecting things like access to affordable prescriptions, there's similar things with some of these trends, with the underemployment, with food insecurity, where we can kind of guess like, oh, well, did food insecurity improve because programs that kind of stepped in to fill voids when, for instance, schools closed, and that cut off a lot of families' access to just lunch every day or meals every day. So those are sorts of things where it's helpful for other folks besides us to then be able to say like, oh yeah, I work in policy, or I work with these local programs, and here's what happened in this area that specifically, where we have the numbers that look at that kind of overall, but not necessarily like, well, what were the specific changes that happened that kind of facilitated this trend. But so we did see kind of this like opening gap in underemployment that is now starting to close up. And we actually see there are some improvements. The Black underemployment rate is actually lower now than it's been since we first started doing the statewide survey. So that again is something where like, why did that happen? Not sure. There's all sorts of like really complex things at play, policy and just other factors in terms of hiring and things, or people changing their definition of, you're working part-time and you no longer would prefer to be full-time because now you have your kids at home, or because you have health problems that are keeping you from being able to work full-time. So it could be really complex. And those are the sorts of things where we don't necessarily have all the answers to something like that. So we also, for the first time this year, asked about gun violence. And this was only posed in the 5 largest cities. But what we found was that overall, 37% of survey respondents living in those cities said that they were afraid of gun violence in their town. 5% had a relative who was shot in the past year, and 8% witnessed a shooting of some sort in the past year. And all of these, again, they're kind of, this is another one of the sorts of questions where we see like large differences, even within places that we might think we could like lump all the cities together, and we see that actually we can't, that these are all things that are where Hartford is really hit hardest, kind of across the board, and Stamford residents are much less concerned about those things. So this was, we don't have a, we can't do trends on this one. This is a new set of questions that we just started asking, but this is something that I think other organizations actually had asked for. So, and I'll just remind folks again that if there are things like this that you would like added to the survey or to the in-depth focus group style sessions, to let us know, because we do add questions based on what our partners need to be able to measure as well. Another thing that we look at, this is one that I think is always really interesting, because this is another one where you see kind of these divides opening up, is rating the job done by local police. So folks that say that the job done by the police to keep people safe in their area is either excellent or good. So kind of lumping those two responses together as an approval rating. And so 75% of adults across the state said that the police where they live were doing an excellent or good job. But then we have these wide gaps. And so some of those gaps occur by the type of town, some by race, and then increasingly it's been by age. So that was a trend that we saw. I don't have it up here, but that was a trend that we saw where that approval rating for young adults really dropped off in the past. In the 2020 survey, I believe, was lower, but then especially the 2021, where that really dropped off for younger adults, and just a much bigger gap opened up than there had been previously. And so I think, it's interesting because these divisions will come up even within a town. So even within people who are dealing with the same police department then have really different experiences with that police department, especially by race and income, we'll see. But then also looking at not just lumping together as like excellent or good, but being able to actually look at a whole spread of the answers that people give, because it is also useful to, so this is, people scale it as excellent, good, fair, or poor. And so sometimes it is useful to be able to see who's saying, who's rating something like this as poor. This is something we do also with the self-rated health question that I think Kelly mentioned. We will sometimes look at that as like, who says that their health is poor, because that also, can be as good an indicator as people who say that their health is excellent. And so here again, you see groups where the share of people saying that the police are doing a poor job actually outweighs the share saying excellent. And so this is another place where you can really see those gaps open up. And so all of these sorts of things, these factor into some of the things that that Mark mentioned earlier about trust in local institutions, feelings of safety overall, that then kind of become part of like, well, in a crisis, how do you respond? How do communities respond? Who do you trust? Do you feel safe? Where are you getting information from? All of those sorts of things that now are really at the forefront of how we deal with health and safety in kind of a crisis mode. So I think I'll leave it at that, but I know folks have questions that I'm happy to field or pass to Mark if they're Mark specific questions.
We have had some good comments and back and forth in the chat, Camille, and there is a question for you or Mark about validity from Christine. She asks, is there any information that backs up self-report data as valid compared to other types of data?
want me to take that?
Yeah.
That's a question people ask often. And just so you know, when we're developing the survey, we're usually taking questions that are asked like on a large national survey or like a CDC survey, and then just fielding the same question in Connecticut so we can get data about Connecticut and about communities here. So because of that, most of the questions have been extensively used and tested and validated to show that what they're measuring is accurate, and also that the question itself is valid in the sense of like, you know, it's actually measuring something. If you repeat it several times, you get the same answer. And we can do that with our own data as well internally. Like we have a question about sidewalks in your neighborhood. And if you look at over time, the percent of adults who say they have sidewalks in their neighborhood is like exactly the same every year by each area. So and that's not a surprise because they don't build sidewalks very quickly, you know, in cities in Connecticut. So that helps in some sense. And with other questions too, like if you look at we have questions about asthma and emergency room use and about police stops for tickets, for traffic tickets. And if you look at the percentages of people who go to the emergency room from like actual state data and our survey, it's identical. Same with like police stops, like the racial disparity and the number of people who get stopped for traffic tickets is about the same, you know, by race, ethnicity in our survey versus the data that the state collects through its traffic ticket monitoring. So I don't know if that doesn't get your question, you can also raise your hand and we'll unmute you to explain more.
Yes, I'll just echo Mark and encourage folks to enter stuff in the chat or to use the reaction option at the bottom of your screen to raise your hand if you have comments or suggestions. In the meantime, Camille, others have been asked this question and I'm going to pose it to you as well. Is there anything in the data so far that has surprised you or something that sort of sticks with you and that you're curious about?
Yeah, I think that the big thing that we noticed was looking at the trends that I mentioned, those, you know, when I first looked at pulling the trend data together from 2015 through now, I think I was really expecting to see, you know, food insecurity at kind of crisis levels. Yeah, I was surprised definitely with that one to see that actually dropping. And, you know, so that's something that we talked about kind of all like pulling together, like, well, what, you know, like what were different policies that might have played into this? Does that mean that, you know, the programs that different like health departments and school departments and everybody pulled together to kind of fill in when the schools closed really had that much of a reach that it you know, met the needs that people had, that people like already had, or exceeded those needs. If, you know, food insecurity is better now than it was pre-pandemic. So yeah, I mean, that is, like I said, that's the sort of thing where that probably ends up being folks figuring that out locally, what happened and kind of what worked, and how to, you know, keep those numbers low, you know, keep it so that like if something worked during like the beginning of the pandemic in order to make food available to people who already had that need not being met, how do you then keep that, you know, make those sorts of programs permanent? And I know that that is something that has come up in a number of policies around like housing and food and healthcare access, or even just like, you know, telework, the places that are saying like, yeah, actually, we're going to just stay like having a remote option open, or we're going to stay at a 4-day work week. Those sorts of just like changes that are people kind of tried them out and said, oh, actually, this works. We'll stick with it. So yeah, I think that those couple of things, food insecurity, underemployment, those sorts of things that we were really expecting to be sky high and then weren't, was really surprising.
So our chat has fallen silent. So I'm going to fill that silence. Ooh, we're getting a question. Excellent. I see Sten asking, the New York Times reported national poverty rates to have declined during COVID-19. This is attributed to the funds provided by the US government. However, with the collapse of so many small businesses, the data from next year will be quite critical to assess. Can you comment on what we expect from DataHaven data going forward?
Yeah, I mean, so this is one of the, so we do our survey only every 3 years normally. Last year was kind of shorter version that was more COVID specific. So we won't have our own survey data next year that would be able to look at that, as far as I know. I don't know if Mark has
Yeah, we might.
other plans. Yeah.
Yeah, we'll probably do a small survey at least, but
Okay.
maybe not the most granular version of it.
Yeah, I would say though that one of the major sources that we use for our kind of day-to-day work, aside from our survey, is the Census Bureau does the American Community Survey every year. And that comes out for larger areas, that comes out as like a 1-year set of data. And then for smaller areas down to census tract level, that comes out every year as a 5-year average. And that's like a really, really rich data set. And we use that almost every day for our work. So that might be somewhere to, that's somewhere that you can see a lot of data on not just poverty rates, but also kind of low income rates. So that we do as living in a household with a total income that's 2 times the federal poverty level or lower, which especially in a place with a high cost of living like Connecticut kind of gets at a better measure of, just poverty or like financial struggling. So that might be the sort of data that will be, starting to come up in the next ACS, and would be like a more like short time span sort of data source.
Yeah, I can add one thing to that too. Like in the ACS data where you have it year by year, it actually shows Connecticut's income is going up pretty significantly since the end of the Great Recession up to the pandemic. So the ACS is only up to 2019 at this point, but you see that increase. But if you break it down by city, it's like there are large increases in Stamford and Norwalk. And then if you look at Waterbury, the income's actually going down still during that time. So it's important to be able to disaggregate using surveys like this to show, even if like the whole state is getting much better in something, there's areas that are getting worse, or also the issue of inequality. So with financial security improving, for example, it looks like it improved for all groups, but some groups improved on that more than others. So that's also something to keep in mind. The rate may have dropped like 75% for one group, but only dropped 25% for another group. So we plan to continue to measure that through our survey and other data sources.
And then I'll just say one more thing on that. That's just kind of underlies a lot of the work that we do. That people, it's kind of hard to appreciate, I guess, but when we're looking at data, we're looking at stuff that's already happened. So there's always a lag between something happening and it then being measured and then put together and then analyzed, and then we're able to share it with you all. So, so I think that the lessons that we can get about the pandemic through data, we're really going to be teasing apart for the next several years.
A long road to hoe, isn't it, Camille?
Yep. Yeah, got a lot of code to write.
Very exciting. I'll put out another call for any last questions or comments or suggestions from this great group. Any additional questions folks would like to see in the survey? I hope I'm not speaking out of turn, but that Mark and his team are always happy to take suggestions and feedback about the survey and its contents and what will be going forward in those focus group like conversations. I'm not seeing anything come up, so I will just conclude this session and thank Camille so much and just say I appreciated the entire event today and toss it over to Cara, I believe, to take us home.
Yes, thank you, Kate, and thank you, Camille, Mark, and the rest of our presenters and contributors, Josh, Brita, Fawati, and Kelly for making time today to share the data and engage in this important conversation about well-being. And I will pass it on to Mark for closing comments.
Yes, I just wanted to thank our sponsors again for making the survey possible, for the event possible, also our advisors, our advisory council and research advisory committee that advises us on data collection and what to study. A recording will be available after the event, and also slides, the press release, the crosstabs, the slides from today, we can make those all available to attendees. We look forward to having you back when all of the data are out a little bit later in this year. So thank you so much for attending today.